my knee's feeling pretty good, but I get this pressure tightness in the back of my knee. So we flipped over, the popliteus is tight. And why is that clinically significant? Well, it's involved with the lock-home mechanism. It's also attaches to the lateral meniscus, and it's also involved in stability of the knee and flexion. And then as I'm working on her popliteus, and like Joe was using, I'm using the bracelet, and it's coming through, and I just have her lying on the ground plate. And she goes, also I was noticing today, I didn't really want to pop up from my ready position. So what do you mean? Well, I didn't really want to extend my knee. It just didn't feel good. And I'm like, of course it's your popliteus, because that's the lock home, screw home mechanism. So I did some myofascial release, some pin and stretch right over the popliteus with RET plus 30%. And that was the case, the first case of knees that we did today. So I wanted to share that. But let's look at some functional assessment of the knee, because that's where I live. And not all my patients are high-level athletes by any regard. But let's look at a little stuff. What do we see a lot? Is we see this. We see the valgosity of the knee. Now, I know that one kid that had the Oates procedure was varus, but a lot of people have this. The hip drop, the knee goes into valgus, may or may not have some pronation. So what do we have to look at? Where is it coming from? Is it coming from the foot? Is it coming from a weak glute med and you're getting internal femoral rotation and adduction at the knee? Is it tightness in the adductors? Hey, maybe it's just weakness of the posterior chain and they don't have that eccentric loading, that squat, right? The hip hinge. So that's all the stuff you have to look at. Could it just be VMO weakness? Terminal knee extensions are needed. It's possible, but this is real common in life, let alone in athletics. So we have to look at the foot and ankle for navicular drop and navicular drift. Is there an imbalance down here? Well, then that's got to be addressed, okay? When the foot flares out, external rotation, then we know the whole lateral chain's involved. Biceps femoris, lateral gastroc, maybe the piriformis. So just put your thinking cap on of dysfunction that people present with in life. And then it translates to activity, and then it translates to sport. So that's what we want to fix. Now you can fix it however you feel most comfortable. So I'm just going to talk a little bit about assessment. Then I have a couple of more clinical cases that I saw today. You're using this as rehab, Joe, but guess what? It's a great test, the step down test, right? You want to make sure the hips stay level, all right? You want to make sure you're not getting any internal, external rotation of the torso. Eyes, shoulders also got to stay level. Look for that valgosity in the knee. Because if the hip drops or if the hip hikes, it's still glute med weakness, right? So you're getting a hip hike on this side, you get a hip drop on this side, that still means this glute med's weak. This side, the QL is compensating. This one, it's not. So got to strengthen that glute med. And if you're going into valgosity again, glute med's dysfunctional. So a step down test is great, not just for rehab. It's excellent as an assessment, and it's simple and it's good for everybody because we're all up and down steps. So you look for the hip hike, you look for the hip drop, outward rotation, external oblique dysfunction, internal rotation, internal oblique dysfunction. Is it a balance issue? Maybe. Then you do sensory motor testing, real simple single leg stance, eyes open, eyes closed to figure out that's the dysfunction. All right. And again, is it their knee or is the knee just stuck between the hip and the foot? Again, be thoughtful about it. Ankle dorsiflexion is real important when we do these motions. Great article, 2021. In the absence of sufficient ankle dorsiflexion, you get compensatory pelvic tilt, contralateral pelvic drop, and hip flexion. You can't do a good step down, but don't assume it's all up in here like I was just talking. Maybe it's ankle dorsiflexion, and Laura did a bang-up job on the ankle. And next time she comes back, I'm definitely going to tune in on how she's using Winback and Tecar to rehab all of her ankle sprains at high-level basketball players. So I would rewatch that one if you didn't see it. It was a great AMA on the ankle. Jump downs, that gets a little more aggressive. Most people can do them. We're looking to see if they go into valgosity, right? If they have that valgus shift or narrow foot placement, we're thinking ligament dominance. Those are the people that are vulnerable for the non-contact ACL tears. Quads are weak, adductors are tight. That's what you got to fix. That's the dysfunction. You know, if with their jump downs, they're getting a shallow, hard landing, and they're not going into that ready position. They're getting less than that 30-degree knee flexion, or there's full extension, right? Then you got to think those quads are dominant. They're too tight. The hammies are weak. They're landing in a flat foot position, also quad dominance, weak hamstring, weak glute, medium max. So, you know, excellent diagrams with the exercises that Joe saw. It was really good mechanics, doing the step downs, doing the jumps. People need to do that, not just with their Tecar, but in life. We can use these assessments to see if they're dysfunctional, and then we can rehab in those same positions. And with the Tecar, it just helps get better vascularization to the tissues. And then here's the corrective exercise key. Pretty straightforward for everybody who's on the call, all right? It's kind of a review. You know, if they're locked out when they land, you got to get them in that soft landing. If they're extended hips, again, get them into, I just get people to land like a gymnast. I tell people, stick the landing like a gymnast. Basic stuff, and the balance deficits, you know, it's proprioceptive training. Or do they just not understand? Is it a skill deficiency? They just don't understand. You have to work on agility, acceleration or deceleration. But again, basic stuff, I think most of us know it, but I wanted to review it. Tuck jumps is the next one we'll talk about, another more advanced for our athletes at a higher level. Same thing, we're looking for foot placement, making sure those knees come up symmetrically, making sure they come up past parallel, looking for the touchdown. If you have an Optigate or one of those pressure plates that measures the seconds off, that's great. If not, just visualize it. Look for that even landing. Look for the even pressure. Do our high-level people need the data? Yes. Do our everyday people, can we see the dysfunction? Yes. The guy with the total knee and the guy who had the patellar tear, quad tear on the other side, he's not doing these. No way. We'll keep him in step downs, okay? But for our higher level athletes, this is a great screen. And, you know, there's leg dominance. You're going to see uneven foot plant. You're going to see a unilateral shift. The dominant leg, you're going to get more torque and stress. The non-dominant leg, you're not going to get efficient shock absorption, all right? If the knees aren't coming up past parallel, you're thinking of core instability, all right? Trunk or core, if the knees aren't coming up over parallel. So basic functional assessments you can do for the knee. And also you got to worry about neuromuscular control, because if that knee's not tracking over the foot, you're going to be vulnerable for either patellar tendon issues or, of course, non-contact ACL injuries. So functional assessment of the knee, I want to throw that in. When we need to work the glutes, remember, glutes have to maintain full body weight. Great article from 2012, and just simple exercises. Phase 1, phase 2, a little bit harder, right? Multiplanar, balance, proprioception. Phase 3, getting into the planks and some challenges with different perturbations. But remember, glutes got to be really loaded if there's a glute medius instability, because it's got to maintain full body weight dynamically. So doing 3 sets of clamshells with a red TheraBand is not nearly enough load. These people really have to be loaded with their glutes. Are these the only exercises? No, but good visuals I found, I thought I would share. Next case, arthritic knee, all right? So we started off with a little bit of CET, all right? So get a thermal effect. As we were getting the thermal effect, then from there I went on to doing some RET. Did I have imaging on her knee? No. 56-year-old female. Visually, you can tell the knees are arthritic. She was having some medial joint line tenderness. So when I put on the bracelets, I just used my fingers along the medial joint line when I did the RET, just to kind of coax some of that energy into the cartilage. I know it's avascular at this age, but anything we can do to stimulate fluid in through there. That little, putting a little lotion on my forearms is kind of important because I'm skinny. So when I use the bracelets, I find if I don't put a little lotion on, well, I might burn myself if the band catches my ulna or my radius distally. So I don't have really big forearms. So that's what I do. And then I get in there with my fingers. Yeah, there I'm just showing the RET and how I got my fingers in through there and got right on the joint space. And just helping to get to the cartilage a little bit. I'm usually about 30% with that. If I go to 40%, I can start off okay, but then it gets too hot for me. Like I said, I think it's just because I have bony forearms, but that's just my guess. But very rarely can I do more than that. I had the small RET head on somebody today, which I'm going to show you. I had to back it off to 20% because it just got too hot. This patient, difficulty with stairs, arthritic knee, same type of thing as what Joe is doing. We have the ground plate and the RET plate, driving it through the knee. We had her do step-ups. That's a 9-inch step-up. Had her do that for 5 minutes. Guess what? No problem, 1 session. Next time she came back, no, my knee's great. I don't have any problems with the stairs. It was more of an issue going up the stair than down the stair. You know, personally, when I hear it's a problem going down the stair, I'm thinking about that VMO and more patellar tracking type stuff. When I hear up the stair, I'm thinking more glute, hip weakness relative to the quads. Just where my headspace goes. This was not today, by the way, all right? This was today. Guy was on vacation, slammed his knee, fell, slammed his knee. That was 6 days ago, came in today, still had some suprapatellar swelling. If you can see, if we zoom in, it still blots a little bit above the patella there, there it is. You can still see the fluid. So I took this RET because I really wanted to focus it over here. I went with low pulse because I didn't want too much of a thermal effect, but I wanted to drive circulation through it. This started to get hot at 20%, which I thought was interesting. Might have been because it was towards the end of the session and there was less of the conducting gel, but it did start to get a little bit warm. So I backed him off after that. And I think it looked great. It looked better when he got done. We'll find out when he comes back how it worked, but that was today. So that's the second knee case I had today with Tecar. This is the third knee case I had today with Tecar. You can see this knee is a little osteoarthritic. And that's what he was complaining of. My knee is stiff, it's sore, non-diffuse pain. He does yoga, it just bothers him. So we have the dispersive pad, the circular dispersive pad, and I'm doing CET. I wanted to get some heat in there. After we got it loosened up with some heat. Now his squat mechanics aren't great. So we had to work on his hip hinge, the purpose of another video. So we didn't, you can tell this was not edited. I wanted to start out with the CET and then go to the RET. So this was not edited, so we did it off the cuff. CET first, I wanted heat on this guy. It's arthritic, it's stiff, it's tight. And we had to do some functional squat movements there. So a few different cases. The gist of it is remember to do functional assessments when it comes to the Winback and Tecar. Just this afternoon, 3 different knee conditions presented themselves, all unannounced. And we use Tecar on all 3 of them. So it is part of your multimodal paradigm. So that's what we have for you guys. Hopefully it's clear as mud. I don't know.
Thanks, Don. We
You're
always
welcome.
appreciate your